Hi, my name is Ryan Leifer, and my topic is increasing quality while reducing costs, strategies, and methods. And I decided to do this topic because I kind of want to get into healthcare management or possibly consulting post-grad, and I thought that looking into some of these strategies could possibly help me out down the road or just kind of just get a little sense of what I would possibly be doing in the future. So a majority of the people who utilize the United States healthcare system realizes that the costs for healthcare are on the rise, and according to the World Health Organization, the U.S. has the highest cost for healthcare compared to any other country, and many health science majors would know that, but that's just kind of the stat from the World Health Organization, and this is concerning because we are not at the top of the list for healthcare outcomes, and I feel like if a country is spending the most on healthcare, that they should have the highest outcomes, and we're currently not there. And it is up to health administrators and policymakers to investigate different strategies and programs in order to reduce costs and increase quality and implement them into their specific organization, whether it be a hospital, a dentist office, just something like that. In this presentation, we'll examine our healthcare system and look into management approaches, strategies, and programs. So why is our healthcare system so expensive? In a textbook written by Sultan Young titled Healthcare USA, the authors discuss the reasons as to why this is. The authors give many reasons as to why it is, but the central reasons they argue revolve around technology, the aging population, chronic conditions, and government programs. As society becomes more advanced, our technology does as well. Newer and effective technology is always more expensive than previous technology, and that's the case for healthcare as well. Whether it be medical hardware, equipment, or information technology, the aging population is also another reason. As healthcare continues to become more effective in being able to keep people alive and live longer, this enables people to utilize the system for a longer period of time, and this can have many fiscal consequences, such as who pays for it and overutilization of healthcare system as a whole. Another large reason is chronic conditions. These are long-lasting diseases that cannot be cured in one visit. 20% of the population uses 80% of our healthcare dollars, and chronic conditions are a main reason why this is. They require frequent visits and multiple expensive surgeries. I read somewhere that Alzheimer's is supposed to bankrupt our country by the year 2050, which is pretty alarming. So, as a country, we must combat conditions like these or organize our healthcare system in a different way so this does not happen. A final reason is government programs. Government programs such as Medicare, Medicaid, and Veteran Affairs Services. And these are paid by the people through taxes to the government. And Medicare and Medicaid are very expensive to the government, which is why there have been talks to restructuring how these programs work. Succeeding in running a healthcare organization is every manager, administrator's, and policymaker's goal. In an article titled Evaluating Priority Setting Success in Healthcare, a Pilot Study, the authors tried to determine ways in succeeding. The authors argued that decision makers have a growing pressure to improve their priority setting and to be accountable for their decisions. They developed a conceptual framework on the necessary elements for success, which go into detail of process and outcomes. They have also developed an evaluation tool for these and have implemented them in hospitals. The process elements are stakeholder engagement, explicit process, clear and transparent information management, consideration of value and context, and revision or appeals mechanism. The outcome elements are stakeholder understanding, shifted resources, decision-making quality, stakeholder acceptance and satisfaction, and positive externalities. The authors had a lengthy evaluation process for each of those elements, which I can't really get into because I only have a 15-minute presentation to do. But those are the main elements. The authors stated that the use of this framework and the process that, quote, organizational leaders can develop a greater capacity to incorporate relevant reasons for decision-making and provides an explicit structure to facilitate organizational learning and innovation. So there are a number of different management strategies when it comes to healthcare leadership. I looked at one in an article by Berwick titled Continuous Improvement as an Ideal in Healthcare. The author looked at two strategies and how they can be applied in healthcare. The author gives an example of two foremen overseeing a production line. The first foreman warns his employees that he can see them working, he can measure their work, and will pick out the workers who are unprepared and inadequate to do their jobs and replace them if need be. This is referred to as the theory of bad apples. The second foreman emphasizes to his employees that he's here to help, that they have common interests, and he is able to provide lessons if something goes wrong. and to look for ways to improve. The author suggests that if managers uses the theory from foreman number 1, that he is giving off a message of prove that you are acceptable. This in turn will lead workers to be afraid to ask for help and be on edge because of the climate. The author says, quote, when quality is pursued in the search for deficient people, those being surveyed play defense. He also states that, quote, when one is clear and constant in one's purpose, when fear does not control the atmosphere, when learning is guided by accurate information and sound rules of inference, when suppliers of services remain in dialogue with those who depend on them, and when the hearts and talents of all the workers are enlisted in the pursuit of better ways, the potential for improvement in quality is boundless. The author clearly argues that he believes that the theory of continuous improvement is better, and personally I believe that working for Foreman 2 would be more enjoyable and fulfilling, as well as I think more effective in the long run. The study of readmission rates has been a recent topic of interest for many researchers. By studying these rates, one can identify risk factors that influence readmission. This is done in the interest of reducing readmission rates and therefore cutting costs. In an article by Friedman and Basu, they conducted a study called The Rate and Cost of Hospital Readmissions for Preventable Conditions. The study specifically looked at readmissions for preventable conditions and researched the rate and cost that these readmissions were costing the hospital. This descriptive study gathered all of the discharge data from 4 states in 1 year. It investigated discharge and readmission data for 6 months after discharge for patients with preventable conditions and the costs that would go along with these illnesses. They classified 16 kinds of admissions as preventable through a prevention quality indicator based on the condition of the patient diagnosed after admission. This study was conducted in order to calculate how much money it was costing hospitals to treat preventable conditions. The study found that the hospital cost for preventable conditions, for preventable readmissions during the 6-month period was around $730 million. And the author suggests that by treating preventable conditions effectively the first time, hospitals can save money by not having to readmit them in the future, and that makes sense. Another article I looked at titled Post-Discharge Environmental and Socioeconomic Factors and the Likelihood of Early Hospital Readmission Among Community-Dwelling Medicare Beneficiaries. And this researched the likelihood that a patient would be readmitted soon after they discharged. This cohort study looked at 1,351 Medicare beneficiaries that were admitted to hospitals and survived over 1 year after they were discharged. It measured early readmission as being readmitted within 60 days of initial discharge. They also gathered post-discharge environmental and socioeconomic status factors of the beneficiaries, and these were things such as availability of care at home, marital status, persons living with them, and how well one can maintain their own health. Socioeconomic status elements consisted of education, income, and social position, and they found that 15% of the Medicare beneficiaries encountered early readmission, and also that patients that cannot sufficiently take care of themselves had a readmission rate of 50 to 75% chance. And this study suggests that if healthcare organizations can identify these risk factors prior to discharge, they can develop health programs or discharge plans to avoid costly readmissions. Another thing I researched in order to reduce costs while increasing quality was strategic staffing. And in an article written by Needleman in 2006 called Nurse Staffing in Hospitals, Is There a Business Case for Quality? It was a quantitative experimental study to determine if there was a way to reduce nursing payroll. The purpose of the study was to determine that if hospitals with higher amounts of registered nurses that worked in short shifts were more cost effective and showed higher health outcomes than hospitals that have fewer nurses and work longer hours. And they examined 800 emergency care hospitals in 11 states, and it looked at the facility's discharge and nursing data. It's simulated the effect of the increased nursing staff in these hospitals in 3 different ways. The first way, it's stimulated the numbers of hours they worked to the 75th percentile of the national average. Then it simulated the number of nursing hours per day to the 75th percentile national average, and then it replicated the effect of increased nursing staff to the 75th percentile of the national average. And the results showed that the increase in nursing staff slightly increased costs, but indicated that it reduced the number of hospital stays and reduced the amount of in-hospital deaths. And the authors suggest that the slight increase of costs due to higher nursing payroll is cost-effective if it reduces the length of stay of inpatient and in-hospital deaths. Health prevention and promotion has been an area that healthcare leaders have been looking into in order to lower costs while increasing outcomes. Programs such as early screenings for diseases have been shown to be effective. For example, if someone goes to the doctor for an early cancer screening and there's evidence of cancer in the body without the expression of the symptoms, doctors believe that they have caught it at a more manageable time. And this can lead to a better chance that the cancer is eradicated sooner, which will lead to lower costs all around and obviously a good health outcome. This author wrote a chapter in a health promotion book titled A Framework for Health Promotion, and he pretty much just discusses the approaches to prevention and promotion in order to have higher health outcomes. He discusses 3 challenges, which are reducing inequalities, increasing prevention effort, and enhancing people's capacity to cope, and 3 proven strategies that have evidence based towards them. And those strategies are fostering public participation, strengthening community health services, and coordinating healthy public policy. And the proper implementation of these strategies have led to a healthier community through promotion and prevention. Healthcare leaders are always striving to be effective in what they do, and one thing I found out when I was researching was the cost of medical errors. And they have a large impact on costs as well as outcomes. And these errors can hinder patients from leaving a facility in a timely manner, can cause an injury, and in some cases cause death. One article I looked at titled Excess Length of Stay and the Economic Consequences of Adverse Events in Dutch Hospitals. The authors looked at the cost of adverse events, preventable conditions, and patient characteristics associated with excess length of stay and costs. They found that out of 2,975 patient records that a shocking 325 experienced an adverse event, which I thought was a huge number. And this was caused from improper or inadequate delivery of health care, and these events caused the patient to stay an average of 5 more days and cost the hospital an average of $2,600 extra. And the study showed that adverse events and preventable events lead to substantial excess length of stay and increased cost. In another article I looked at called The Impact of Medical Errors on 90-Day Costs and Outcomes, they conducted a descriptive study to look at the impact of medical errors on surgical patients. They studied over 161,000 major surgeries for a year and halfway through an insurance claim database. And the purpose of the study was to assess the costs and outcomes of medical errors during surgeries. The researchers defined 7 patient safety indicators, or PSIs, and attached a monetary value to each. They measured the PSIs, how many PSIs occurred out of every surgery performed, and investigated the medical consequence of each. The study found that 14 PSIs occurred during the study period, in which 2 deaths occurred, and the dollar amount of the cost added up to $28,218, which is a significant amount for a hospital that's always trying to cut back. And the study suggests that these errors affect the patient long after they are discharged and can cost the healthcare facility enormous amounts of money from lawsuits or follow-up care. The last thing I looked at was technology. The implementation of appropriate technology has played a major role in efficiency of healthcare, whether it be telehealth or EMRs, electronic medical records. Technology bridges many gaps in order to deliver care more effectively and in a timely manner. The article I looked at was titled The Impact of Health Information Technology on Quality, Efficiency, and Costs of Medical Care. This paper did a systematic review of many other papers regarding health information technology. They looked at the efficacy of decision support systems, electronic health records, computerized provider order entry, and results management. They found that health information technology has a major effect on quality, with decision support and clinical monitoring based on large-scale screenings and the aggregation of all the data they collected. They also found that it had an effect on cost. The implementation and maintenance of these technologies cost the facilities, because that's pretty obvious, but this is similar to any sort of service because they calculate the cost. It cost them to put these technologies in, but it did not measure the cost if they would not have these technologies and all the problems they would run into and how inefficient they would be without this technology. So in conclusion, it's important to know and care about our healthcare system when it comes to cost and quality, why succeeding in a healthcare system is important, and approaches to management and staffing strategies in order to do so. I looked at topics to study in order to improve healthcare delivery system when it comes in terms of cost and outcomes, like process improvement, similar things to that. Looked at programs that have improved the health of people and the implementation of healthcare technology and its effectiveness. Thank you.